So we now enter the question time for the speakers. Please do make your way to the mics. In the meantime, I think, Chiara, you had some questions to start us off.
Yes, thank you. So the first is for Lorenza. In your presentation, you alluded to the fact that there is an organized pathway for referral, for example, access to some targeted therapies. You made the example of zanidatamab. Does it mean that in Italy you have a national MDT where you discuss the patients, or it just goes voice by voice and whoever knows who's the best expert?
You forgot how Italy works. No, we don't. We don't have nothing at the national level. It's also, the molecular profiling has been established on a regional level. So no, we don't.
So the MDT are only at the institutional level?
Institutional level, and in a few months, regional level.
Yes, Yuan, then I have in my second.
I'd like to thank all the speakers for sharing with us the perspectives from their individual countries. Just one comment, first of all, it's amazing to see what's happening in Thailand, and demonstrating that if you can really get screening, prevention, and early diagnosis right, you can change survival hugely. My question is really to the broader panel. We know that about 1 in 9 patients with cancer of unknown primary will have a cholangiocarcinoma. How are you detecting these patients, picking these up in your individual countries?
Chris, do you want to start off with that?
Yeah, I'm aware of the data, so I don't believe a cup, in my opinion, this is a cholangiocarcinoma. That's a very nice way of starting it, the discussion. I have to say that in Belgium, it is like that every subspecialty organizes its own oncology. So I'm a hepatologist, but I have a special recognition in digestive oncology. So the majority of oncology is done by the subspecialists. It's the same for the pneumologist and so on. So this helps a lot. So that there is, if it is in the liver and you find, they don't find the primary, it's very likely that they end up in a GI service, and so then they ask for the advice. So most of the time we get the telephone then. But I have no hard data. That's what you are asking. It all depends on how these tumors are registered in the Belgian Cancer Registry. It's all dependent on what pathology is doing and how far that they are going. So you need to make the link between the molecular testing then and the histology, but not in all cases. As I explained to you, you will have molecular data. So this coupling still has to be done at the cancer, because they don't gather the molecular data yet in the Belgian Cancer Registry, but it is something that we're working at, and then we will be able perhaps to answer this question on a national scale. But in the meantime, we need a kind of project that we put the effort and on it. There is a company that is making this as a kind of marketing strategy for its compound in cholangio, that they say, think about cholangio. That's one way, of course, of putting attention on the issue.
Lorenza, how do you deal with CUP in Italy?
Yeah, we don't have a national program. As in Belgium, most of the patients are referred to centers where GI cancers or hepatobiliary cancers are treated. I received some of them. And when we have an adenocarcinoma in the liver, we do all the tests, including the molecular profiling, to diagnose in most of the patients a cholangiocarcinoma. It's strange, but I received last week a patient with lesion in the gallbladder and liver metastasis that was referred as adenocarcinoma of unknown primary. And so just based on the CT scan, I changed the diagnosis in gallbladder cancer with the liver metastasis, but it's an issue. There is no large-scale program.
And Wacharin in Thailand?
I would say that in Thailand, as I mentioned, we can put it as a national program, but still a lot of effort needs to be keep moving forward, because until now it's almost 10 years of the program, but we still can do 10% of coverage of the rich people. So it's 90% more need to be expanded. And the program has been, conducted in very specific area also. So in this case, I would say that it's a long way to go for Thailand.
Okay. You had another question, Chiara?
Yeah, I had a question for Professor Loilom. I mean, it was amazing to see that your effort and your campaigning has paid and has brought to success. And I think that you have acted on two fronts. On one side, you have increased the screening of the liver flu and then treated the infection, and on the other side, increased the education. So in your opinion, up to date, what has paid off more? Have you, convinced your kids not to eat the raw food, or just treating the infection more constantly can prevent the cholangio?
It's a tough question. Actually, we do believe that prevention is always better than cure. So in this case, because our problems has been involved in all age of brains. I mean, we can starting from very young people. So in this case, for them, I think prevention or the education would be very important to change their behavior. But for the older people, it's quite tough to change their behavior. So in this case, we try hard to get them to be to be in the screening program and then get early treatment. So in this case, I think many phases need to be run in parallel, and then it needs to be precise for each of the people. So we cannot, use same strategy for all of them.
I once asked Chiara that question when I was in Thailand to a professor of parasitology about, educating people to eat fish. And he said, well, when you go back to England, you just tell people to stop drinking so much you'd wipe out liver disease. What's the problem? And of course, it shut me up, because a cultural change is actually almost impossible to do. It's a generational effect.
It's a generational effect. So when they start so early, maybe in a few years they will see the.
I think nowadays in our young generation, they have changed a lot. I mean, their behavior. So that eating menu is changed. So we hope that probably like 10 or 20 years in the future, we can see the less number of both OV infection and also the CCA patients.
Yes, as long as it doesn't change to a Western diet, because then you'll just replace that with muzzled.
Sun,
just a crazy left of field question, right of field question. We're now immunising against malaria in Africa quite successfully, I believe. So for a large parasite, you've got countries with endemic disease leading to deadly cancer. I get it, it's difficult to change the cultural norms, etc. Is anyone looking at immunisation across the population, perhaps as a future strategy against the fluke?
So actually, I'm not quite sure whether I can catch up your question.
I think the question was: is there a way to vaccinate against liver?
Okay. Actually, we try to do vaccination, but it's not that easy, because the fluke is multicellular organism. It's absolutely different from the virus. So the vaccinations, still we don't have it so far. And then it is quite tough for as I mentioned, this multicellular organism is quite tough for the vaccinations.
Watrin, I had a question for you, which is, there's lots of talk about liver flu in Thailand. What percentage of your cholangiocarcinoma patients do not have liver flu?
Okay. I would say that based on our data, we check the histories of infection in our CCA patients, and turn out that it's approximately 75% of the people have the histories of fluke relations. So the other factors might be also get involved. We talk about the pesticides. We talk about the hepatitis back to Thailand, but still the majority is there are flukes infection.
And is the response prognosis after surgery or response to systemic treatment differ between fluke and non-fluke patients?
I don't think we have that data so far. So actually, I think we don't have the data so far, whether the difference or not. But if we look at the paper that has been published by the Singaporean group that in collaboration with us, they can clearly show that the flukes-related CCA has lower survival when compared to the non-flukes-related.
There is a question from the online platform, and I think it could be better answered from Chris and Lorenza, as you're both depending from the European approval of drugs. So they're asking, what do you think is the major challenge to really, after an EMA approval, to have it approved at the country level?
The budget. So what we now have is that there are secret negotiations between the Minister of Health and the company on the pricing, and it all depends on how the diplomacy is going on, and there is no disclosure of the final price that is paid, so this is a big issue. So we don't have any control on that process, but it seems to work fine until now. So because we are facing major, we have to 35 billion that we have to cut in our spending for every year for the next few years probably. So I think on healthcare there will be a massive stop, and this will have a major impact on availability. So no, we are in heaven, but we will fall out of heaven next year. And some other patients, unfortunately, will go very quickly to heaven. So my problem is that it's all about money. And the economic situation, the global situation has a major impact. But at the end of the day, it's negotiation of a company with our government. That's the Belgian situation.
Yeah, in Italy it's quite similar. I didn't mention that we have a lot of problems, but all cancer drugs are provided for free in Italy to all the patients. So the problem is to negotiate the price with the company. In the end, we know the price because the hospital, there is point then we pay for the drug and then it is reimbursed. And I don't know why the process is so long. So this is the question. I understand that the negotiation is mandatory because we cannot afford, for instance, the prices paid in the US maybe. And so the price in the end is lower compared to other countries, but it takes 1 year and a half.